Welcome, everybody. Good afternoon, good evening, good morning, depending on where you're coming in from. Welcome to the AI in Action Supporting the Healthcare Workforce in Low Resource Settings. This is a part of the Future of Hospitals and Health Systems initiative that is currently being coordinated between the French Development Agency, Aga Khan Development Network, the Geneva Sustainability Center, the International Hospital Federation, La Chaîne de l'Espoir, and Climate Action Accelerator. So we really thank you for being here. And my name is Aditi. I am a project officer within the Geneva Sustainability Center. And a lot of my work is very much involved with this project itself. Without further ado, allow me to welcome and introduce our distinguished chair for today, Dr. Zeenat Khan. Now, Dr. Khan serves as the Regional Chief Executive Officer for the Aga Khan Health Services in East Africa, where she leads a vast healthcare network that spans 5 hospitals and nearly 50 outreach and specialized facilities across Kenya and Tanzania. She also holds the global portfolio as the head of quality clinical programs and projects for Aga Khan Health Services worldwide, covering 7 countries across South and Central Asia as well as East Africa. In addition, Dr. Khan is a consultant with Joint Commission International and brings over 30 years of healthcare leadership and experience, particularly in hospital and nursing administration, quality improvement, and patient safety. She is also a member of the International Hospital Federation's Governing Council since 2022. And on a personal note, she's definitely one of my favorite people to work with. Please join me in warmly welcoming Dr. Zeenat Khan. Zeenat, over to you.
Thank you, Aditi. You are absolutely the kindest person this evening, and you made my evening. Hello, everyone. What a pleasure to be here today and being the chair for this session. Um, I'm Zeenat, and Aditi has very, very kindly introduced me, and I learned a few new things about myself. So thank you once again. Interesting topic today, AI in action, supporting the healthcare workforce in low resource settings. I'm looking forward to listening to our very, very honorable and distinguished speakers today who range from IT world to clinical world for us to understand and hear from them their experiences and the challenges and achievements related to this topic. But before I do that, let me start by warmly acknowledging and thanking our organizing partners, which Aditi mentioned, Geneva Sustainability Center, AFD, AKDA, and Aga Khan Development Network, to coming together to bring this webinar for us. WHO has talked about low and middle income countries, about our major challenges. One of them is definitely human resources. As we know, 11 million healthcare workers by 2030 will be a shortfall for us in LMICs. Science and technology in many fields are going and growing. And if healthcare wants to catch up and be part of it, we need to ensure that we also work with AI and technology for our decision making and assisting us in assisting our clinicians and our patients. So, with this context, it's so important that artificial intelligence it's going to hold a great potential for us, if not already there, supporting our diagnosis, triage, training, referrals, reducing administrative burdens, and imagine helping frontline workers to focus on high volume, high value clinical care. So, ladies and gentlemen, with these few remarks, let's see that what our today's panel brings together, the innovations and implemented strategies in the field they work in, and what lessons can we take from these honorable panelists for there. So once again, without a further ado, may I introduce our the first speaker, Dr. Vivek Rajagopal from Narayan Health. He'll be speaking to us on scalable AI for clinical and operational impact, something which we all in our institution struggle at some point or the other. How do we get the efficiencies and impact in our clinical care and operational care? With that, Vivek, over to you.
Thanks, Zenith. Uh, Very interesting topic, and very happy to be a part of this elite panel. I'll just give a brief background about Narayana Health, the organization that I come from, to help you understand the perspective that I bring in. We are one of the largest.
Vivek, sorry to interrupt, but please do introduce yourself very briefly as well in your
Of
institution.
course, of course,
Thank you.
absolutely. Narayana Health is one of the largest healthcare chains in India. We run about 23 hospitals and several clinics and medical centers covering almost the entirety of India. And we treat close to 5 million patients a year. We run close to 7,000 beds. And I am the chief of AI and analytics at Narayana Health, which means I look after analytics and AI around every operational area, be it hospital operations, finance, sales and marketing, manpower management, supply chain management, and core clinical AI as well, where we do clinical research and clinical AI work. I've been with Narayana for about 14 years now, and our AI division has been running for close to 10 years now out of those 14 years. We have an 80-member division that does all of this work. Um, Getting to the topic, the way we approach AI in healthcare specifically is I want all of you to think about uh, what is the key activity that all of us see when we walk into any hospital. You know, the key activity that happens in any hospital, it is people sitting and waiting. That is what happens in different areas in the hospital. Patients are waiting to see the doctor. They don't know when the doctor will be available. Patients are waiting for their reports or for someone to call them for their tests. Doctors are waiting for patient reports or results or tests to come up or the patient data to show up on their screen. Some doctors are scrubbed up and waiting in the OT area, waiting for the previous surgery to end so that they can walk in and perform their surgery. So there are people waiting in different areas of the hospital. And we as patients, when we go to a hospital, when we have an hospital episode, maybe once a year or something, when we go for an outpatient, or 4 or 5 years once when we have an inpatient episode, and we have to wait for admissions, wait to get discharged, wait to get into a scan, we dismiss it as a small inconvenience that we have to put up with. But what is this waiting time actually signaling to us? We all know that healthcare capacity or healthcare bandwidth is very scarce. As you mentioned in your opening remarks, Zenith, there is a huge shortage of personnel. And when people are sitting and waiting, it actually signals the underlying inefficiency that is there in the system, which means the bandwidth that can actually be used to treat a lot of people is going in people sitting and waiting. Precious healthcare workers, precious healthcare equipment, all lying idle. So until now, we didn't have the tools to ensure that all of this functions optimally. Today, with the Gen AI revolution and the kind of computing power and big data ecosystem and the kind of advanced algorithms, this is no longer a problem. We at Narayana, what we are trying to do is move out all of the non core activities of the hospitals from the healthcare uh, physical space that is there, which means what should happen in a hospital is only the care that happens for the patient. Everything else, all other administrative activities, all other activities that are not core to the central healthcare delivery should be moved out of the healthcare system. That is what we are targeting. And today, with Gen AI growing at the pace that it can understand data, it can summarize unstructured data, it can converse with people, it can recognize images and audio, and it can suggest or recommend pathways as well. With all of these capabilities, we are trying to see where all we can put it in to ensure that activities that need not take that take a long time need not take that much time any longer. That is what we are trying to do. Compress any activity that is not core. Not core in the sense where the doctor is caring for the patient or when the nurse is caring for the patient. Anything outside of that, we are trying to automate or compress. For example, a common situation in countries like ours, where health data is not fully digitized, is a patient walking into a doctor's office with a 200-page physical records of their past history. Now, the doctor, in the 5 to 10 minutes that they get with the patient, there is no way that the doctor can actually go through and make sense of the 200-page medical records of the patient. So what happens in the end is the doctor asks the patients to go through some tests which they may have already done. They may ask them to go through some investigations which the patient may have already done in their history. And the doctor still doesn't have a full longitudinal visibility of the patient information. The effect is that the care the patient receives as a result of this operational inefficiency is a snapshot care or point in time care based on the problems that the patient is able to present at the time the patient is facing the doctor. Uh, Now, imagine AI in this very scenario. Digitization is still a long goal for countries that are not fully on EMR yet. But AI can fill in the gap by automatically going through the 200-page document and summarizing it and presenting a longitudinal picture for the doctor of the patient, which means instantly your care becomes point in time or snapshot care to longitudinal or continuous care, and also saving the time of the doctor, that the doctor has to flip through and make sense of that document, the mental fatigue of the doctor, while presenting a complete picture of the patient. Um, Similarly, waiting times of the patient, appointment bookings, the queries that the patient has. Now, if a patient post surgery, if they have any queries, they have no option but to call the call center. And then they'll have to see if the doctor is available or not, if some other staff is available. They'll have to patch them in. Most often, patients do not get right answers there, and the patients are forced to call multiple times. Most often, they'll take a call themselves on how they're supposed to handle the situation. All of that, now AI can step in, take the hospital SOPs, and AI can guide the patient on what they are supposed to do post surgery, before surgery, when do they need to come to the hospital. One of the problems that patients typically face is that the patients have to show up to the hospital 1 2 hours before their appointment time, just so that they can sit with a nurse or a physician assistant and fill out their initial assessment form, which is about 100 questions that the patient is asked on what symptoms are they displaying, how long has it been happening, any other family history, any allergies. Now, with AI coming in, they can very easily have the same conversation with AI in their mother tongue from the comfort of their home, which means the nurse's time is better spent in caring for the patient, and the patient's time is also better spent where they get to come to the hospital just in time. And the doctor also has clear, summarized information that AI has compiled. AI is able to understand any gaps in the patient history and is also able to ask correct questions to ensure that the complete picture is there. AI helps in optimizing resource allocation, in scheduling resources. So, all around, AI is able to move out non core activities and reduce the waiting that is there in the hospital. I believe that if we take full advantage of AI in eliminating inefficiencies, we can run hospitals at 2 to 2.5 times the capacity they run today, which means without adding a single bed, we can care for twice or 2.5x more number of patients with the same infrastructure. What that effectively will do is bring down the cost of care delivery, because with the same capital, now you're able to cater to double the number of patients. And when you bring down the cost of care delivery, then you will be able to bring more people into the ambit of healthcare, because affordability is no longer a barrier for them. So that is one of the critical areas in which we look at AI helping us in operations. Another core area that we look at in terms of the clinical side is to strengthen our screening tests and procedures. With AI, we are able to determine much more of the patient's disease profile than the screening tests do today. What we are trying to do is we are taking simple screening tests and seeing if they can predict more complex disease patterns of the patients and predict things early in time so that people come into the ambit of early detection. These are screening tests that don't need to be done on specialized equipment, don't need people to come into the hospital, but can be done outside of the hospital as well, in clinical camps, in small PHCs. One of the screening tests that we ourselves have taken is the ECG, where we are trying to see what all of the patient's disease profile can the ECG itself predict. That will make a huge difference in a country of our population, because so many people now can get screened for coronary artery disease, which otherwise would have manifested as advanced chest pain and them coming into the hospital in an acute condition. So these are the two areas that I broadly believe will help us dramatically improve healthcare in low resource settings, utilizing our bandwidth better, adding more teeth to our screening tests.
Vivek, thank you. Thank you so very much for a very enlightening discussion, presentation of yours. Your last statement, where you talked about resource limited environment, is the question one of our colleagues from Afghanistan has put on the chat, that, tell us about in the resource constrained environment and the ongoing challenges. How can AI-based solution be effectively adopted and scaled to support the wider country's healthcare workers? What are some of the innovative strategies if we want to scale up what you just talked about, your strategies in your institution?
Right, right. We are a very large institution with about 20,000 employees that are there in our hospital alone. And when you have to have such a large health system adopt AI, it is a huge challenge, because anything digital that you want people to adopt, you need to then have a huge training mechanism, which becomes prohibitive in itself to fund. You'll need to have trainers, you need to have training systems, you need to have these people attend these trainings. One of the strategies that we follow, in fact, our goal with AI and analytics in general, is democratization and institutionalization of it. When we say democratization, that means everyone in their role should have access to the necessary data or insight triggered by AI or analytics for them to take their action, which means every action in the health system needs to be data driven. And when we say institutionalization, AI and analytics is not a choice, but it is the process. Very often we observe that analytics is a choice. For example, all of us in our work roles may have access to some dashboards. And on a day when our mood is right, we may feel like opening some dashboard and looking into some analysis and then making a decision. But we can very well carry on with our day without looking at those. So, how do we institutionalize it? Which means it becomes the process. One of the things that we look up to is the way social media has penetrated. Training manuals for WhatsApp or Facebook or Insta. Everyone
Sure.
uses it across diverse profiles. We look to model our health systems, anything that we deliver around these. The usability, if it doesn't meet those criteria, then it is not usable. It doesn't go into production. Anything that we deliver in these has to be omni-channel. Nothing can be just desktop based, because healthcare workers are not desktop based. Several people move about on the floors. So everything has to be mobile, desktop, it has to be as an app, whatever way it supports a tab, whatever way people consume it, it has to be available in all those forms in consumer grade UX. Health systems are generally designed to be very, very boring screens that put
Very good
clinical
point.
workers into depression. So
Yes.
to change that.
Very good, Vivek. Well answered. Vivek, before I move to the next presenter, one of our participant has asked, Vivek, could you repeat the title of first of the 2 points which you talked about, please?
Sorry,
The 2 points. The 2
Yes,
points that you talked about
yes,
related
yes.
to implementation, could you
Right.
repeat those two for us, please? And yes, we would be sending the presentation later and upload it. So just the participants for them to know. Vivek?
In terms of implementation, it is democratization and institutionalization that I
I
spoke about.
loved it. I loved it. If you allow me, I'm going to use it. I think these are amazing, amazing two takeaways I will take from you, Vivek. Democratization and institutionalization. I think these are the two things, whether we are doing a small scale or a big scale, if we follow that, the success will follow. Thank you so very much, Vivek, for a very good presentation to us and sharing your experience. Our next speaker is Professor Asad Mia, and Asad, a colleague of mine, will be speaking about some of his experience, some of his work in his practice. Over to you, Asad. Please do introduce Prof. yourself to the participants.
Yeah, sure. Thank you so much, Zeenat. It's an absolute pleasure being over here. Vivek's talk was fantastic. Thank you so much, Vivek. I've learned a lot already. Zeenat, before actually introducing myself, which I think one of my slides, actually, one of my first slides does get into my role, my newest role. As Zeenat is very aware, I used to work at the Arkan University. I spent 13 years of my life after moving back to Karachi 13 years ago. And it's only very recently that I've joined the Evercare group. And my experience of working with Evercare is about half a year. I joined them full time in January of this year. And so I'm going to utilize PowerPoint. Unlike Vivek, I still require a bit of um, prompting through these slides. So the title I've chosen for this is Beyond the Buzz, where AI, empathy, and equity actually meet. Um, Rather than this particular title, the question that I would like all of you to have in your mind as I talk about my content is, what if innovation followed empathy? I'll repeat, what if innovation followed empathy instead of hype? So just keep that in mind. Next slide, please. So yeah, so whoever's running, yeah, just yes, just hold here. So my role, or what I lead across the Evercare network, is leading healthcare transformation learning programs and systems. So for this presentation, I will abbreviate it to HTLPS because it's a mouthful. It's a mouthful. Um, Whatever all of this actually boils down to is really grounded in patient safety, patient quality, patient experience, staff engagement, ethical work. And we're utilizing innovation, creativity, entrepreneurship, and research tools for whatever we are doing. It's really interesting because Evercare Group or the Evercare Network, it's not academic healthcare, which was my experience in the past. It's for-profit, private equity-backed healthcare, and there are hospitals in several countries. The three countries, well, there were hospitals in India and Bangladesh as well. I am not covering those hospitals because those were sold off. But currently, Evercare has hospitals in Pakistan, Nigeria, and Kenya. My work has been in healthcare transformation processes in all three countries, and it's been a fantastic experience. If I were to kind of really boil this down to or summarize this to, we don't build tech for tech's sake. We enable people. AI comes second. So that's going to be, although this webinar is about AI in healthcare, I would still say that AI will come second because the people have to come first. Next slide, please. So what is the problem? And yeah, you can just kind of keep hitting next if we have the, yes, thank you. So what is the problem in low resource health systems? And I'll be belaboring the point, but I want to make a very strong case for the healthcare workforce that's on the ground. Um, we are stretched, we are stressed, and we are unsupported. Frontline workers do feel invisible. I was one of those frontline workers. I worked as an emergency physician several years in the US, then several more years in Pakistan. So when you're working at the front line as an emergency care provider or whatever busy clinical department you're in as part of a hospital, innovation doesn't tend to be something that you can very easily bring about. Innovation tends to be top down. my message to you is that if you speak to the people on the ground and really get them to share their thoughts and ideas, then you're empathizing with them, and the ideas that come forth will be a lot more um, impactful and potentially sustainable. This fact, like the WHO giving us the estimate of 11 million healthcare worker shortage by 2030, I know we keep repeating it during this webinar as well. Just keep in mind that majority of these will be in low middle income countries, and as time goes on, the inequity will deepen. So what we need is human-centered augmentation. We do not need replacement of human beings, and we certainly do not need disruption, although I've been a huge proponent of disruptive innovation. Next. So what is our AI philosophy? And again, I mean, as I'm learning about this platform itself, Evercare, just take this with a pinch of salt. This tends to be more my AI philosophy or with the people that I work with on the grounds, whether they're in Pakistan or in Kenya or in Nigeria. So we want, or we do utilize AI to scaffold. So to buttress, to put in some checks and balances, but we don't do this at the detriment of patient safety, empathy, equity, and ethics. So AI cannot erase any of those other things. Everything we build is governed, it's iterative, and it's frontline validated. What does that really mean? Is that we do go through a lot of prototyping, testing, iterating. And once we've really convinced ourselves that the tech, whatever tech it is, whether it has AI or it does not have AI, doesn't matter. As long as the innovation is frontline validated, that is when we want to scale. And because we are prototyping, testing, iterating, small wins become much more important than shiny tools. Co-creation before computation. I don't have the time. I wish I had more time to tell you about this, but this is something that I've been building up the concept for more. That basically what it means is that before you get to fancy computational models such as AI or machine learning or emerging technologies, you've got to talk to the people on the ground. I'm repeating this, co-create with the people on the ground, and the technology or the innovation will be much more powerful and sustainable. Thank you. Next slide. So I'm going to move to three case studies. This is all the work that I've been involved in. There has been other projects that Evercare has been doing, but I just wanted to give you examples of something that I've built from the ground up. So this first case study is based in emergency medicine, emergency department. That's my clinical area. I forgot to introduce myself earlier. I am an ER physician. I have I've got experience of working in the US and then in Pakistan as a pediatric emergency physician. And at the Arkan University, I was leading the Department of Emergency Medicine for 6 years. So this program, Equity in Emergency Care or E2CP, was something that I was really excited about. And this was first tested or piloted in Lahore at the Evercare Hospital in Lahore. And it was then further validated in Nigeria. And most recently, it's being considered in Kenya or in Nairobi, where the Evercare hospitals are. So this came out, the work really came out of a pretty simple, straightforward audit-based approach, and I'll tell you a bit more about it. Then we use generative AI. We use that to kind of finesse our triaging abilities, and we created new dashboards for triaging in the emergency department. This was entirely based on the teams on the ground. So hence, it's mentioned over here, team-led redesign. Checklists such as MTEX, which stands for Emergency and Trauma Excellence, helped us simplify access pathways to the emergency department. We found through very simple, straightforward means, which utilize AI, that admissions or the admission process or the admission conversion rate from emergency department to inpatient, you could actually start looking at that very, very closely through these kinds of dashboards and AI supported dashboards. We reduce delay times and we improve some of the equity indicators in the emergency departments. So trust increase through visibility and clinical ownership. Next. Yeah, just so this is a very simple, straightforward example. So MTEX, Emergency and Trauma Excellence, audit assessment for the ED, which had gone through several iterations even before being employed in Nigeria. This was the second cycle done last week only when I was visiting Lagos. And so I don't expect people to actually read through this, but what we've done essentially is that we've been inspired by JCI kind of frameworks and WHO checklists and so on and so forth. So it's a very checklist-based approach, but we're using generative AI to help us further. And we subdivide the checklist, and it's just 2 pages of one page, both sides printed, and subdivided. The KPIs or the metrics are subdivided into very um, intuitive subsections, such as the layout of the emergency department, the human resource, doctors and nurses, MOs and nurses, and so on, technology being utilized, dashboards being utilized, any kind of new technology or new any kind of innovation or research that the department has the appetite for. And we do this quarterly. So every 3 months, 3 to 4 months, we try to do a repeat of this. And every time we've done this, we've kind of validated the longitudinal experience of this. And when we go from one hospital or one country to another country, we are also validating this. And this work has been published, early stage publications, and we presented this at an innovation conference in Boston just months ago. Next slide. So I'm going to show you how we've done the dashboarding. So what you can see on the left the two are panels from the Lahore Emergency Department, the Evercare Hospital in Lahore, and the two right panels are the dashboards from the hospital ED in Lagos in Nigeria. And the different dashboards, the different the way they're appearing different is because they're different EHRs in these two hospitals. Regardless of that, the triaging process that is being utilized in the emergency departments is the same, ESI, Emergency Severity Index. So one of the very important tools for triaging is the same in both the emergency departments. Hence, we're able to compare the two. And so this wasn't being done before. This was part of the Equity in Emergency Care program too, and this also came out in the early stage audits. Next slide, please. So this was really cool. Again, apologies, this is a busy slide, but what you can see over here is really actionable comparison. Lahore is on the left and Lekki or Nigeria is on the right. So the Lahore ED versus the Lekki ED. The metrics of the KPIs listed on the left in the leftmost column, and on the rightmost column is actionable insight. And how did we do this? We were going through, just hit next, please. And at the bottom, you'll see in small font that this was derived from EHR-based dashboards in these two hospital emergency departments and interpreted using GPT-4.0 in a domain-specific GenAI application. So no fancy tool was applied. It wasn't predictive AI. It was very much generative AI, GPT-4.0, because I was training it again and again. And this was months of experience of this. I was comfortable and confident that what I was getting out of Gen AI or GPT-4.0 was reliable enough. And then going from one ED to another ED, from one LMIC to another LMIC was further confidence for me as well. And then this was reviewed by peer reviewers by Conduct Science, a platform based out of Boston. Thanks. Next slide, please. I keep saying thank you because I think I've ended. I haven't. Okay, so just very briefly, scaling this across Evercare, this is intuitive. We just want to go from one ED to another ED to a third ED, fourth, fifth ED within the Evercare network of hospitals, and then go beyond as well, because we are publishing our data as I speak. So we want to enhance using digital triage, AI-driven decision support, ongoing KPI tracking, quarterly reviews to drive continuous quality improvement, CQI, and presenting and publishing, as I've mentioned. Next, please. So this is one of the most fun case studies that I want to share with you, and it's for pediatrics or children. So PD Tales is the name. It originated in Lahore, and then it was validated in Nigeria. So AI-generated stories, which are in multiple languages, and these were specifically for pediatric patients. And I don't have the time to explain to you what a mood board is, but using mood boards, we are gathering evaluations of satisfaction levels from children who are being seen in pediatrics wards, inpatient wards, or as well as OPDs. And we are also approaching their parents, the parents of the children, and we're approaching the staff who are involved in these storytelling sessions. And these have been utilized across the board in the hospital setting. Keep in mind, happier kids leads to more confident caregivers and emotionally aware clinicians. Next, please. And in this slide, you can just see that in sessions in Nigeria and in Lahore, the staff are involved in reading out these stories. In one example, actually, the father is reading to his toddler, and in another example, the staff member Anas is reading to two children in the OPD. And so these stories are a great example of low cost, high empathy, AI driven social innovation and impact. Next, please. And the third example or the third case study is on narrative medicine and how that meets AI. This is a very recent example. This is from last week alone when I was in Lagos and we did this workshop for leadership development. And we had leaders from our all three countries gathering in Lagos. And during this workshop, one of the sessions we did was on narrative medicine, which is storytelling in medicine. And we used AI-based approach so we called it the AI Storytelling Lab, in which small groups were given the task to generate stories utilizing AI, but the stories had to reflect empathy and compassion in medical encounters. So we found that these stories, and because I've been doing narrative medicine work for years prior to that, while I was at the Arkan University as well, that it leads to stronger emotional bonds and better communication. And the leaders do say that they can go up on their empathy and compassion levels as well. So this is a great example of how AI can be partnered with narratives and healing is the outcome that's happening. Next, please. So in the next slide, you can see some of the pics over here that in these workshops, we make people move, and that's me. We're making them move, and that gets them to think further. One of the very simple evaluation questions we asked them was how useful they found this AI storytelling. And 100% of the respondents gave this a very useful or extremely useful. And when we asked them to give us one word or phrase to describe their workshop experience, transformative came across. So this is a great example of how something like AI or generative AI can be utilized in leadership workshops as well for healthcare people. Next, please. So very quickly, I don't have time to tell you about this model that we are working on. So HTLPS is Healthcare Transformation Learning Programs and Systems. And on the left, you can see that learning programs and systems is really the how the scaffold is or the buttress of this is the pillars on which everything is kind of working is learning programs and systems, which become knowledge and system enablers. ISER process, ISER stands for innovation, creativity, entrepreneurship, and research. And you can see that there's certain inputs into the ISA process and there's certain outputs. And very important output too for us is transformation goals because this is part of the healthcare transformation process and social and financial impact are really important to us. And the examples at the bottom of this, E2CP, P Details, Leaders Lab, are the case studies I showed to you. On the right, you can see through a hub and spoke model that we are expanding all of these in Lahore, Lekki, and in Avenue, which is in Kenya. And why is this a hub and spoke model? Because at the central level or the group level, we are powering all of these spokes. And there's a lot of crosstalk. We are learning from the spokes as well. So it's not one directional, it's bi-directional. And we're utilizing a lot of innovation frameworks in this approach as well. Next. And governance and guardrails. AI tools are advisory in this case. They are not being utilized autonomously. Each rollout has clinical oversight. We do have kind of like an IRB or an ethics process in place. Innovations are reviewed by the frontline before deployment of anything. And interestingly, compliance, just by ensuring that we be compliant with our processes, including incorporating AI or any emerging technology, we are not killing creativity. It is actually enabling trust in the people on the ground. And so we treat AI as scaffolding, not substitution. Every tool must earn trust on the ground before it scales. Next. Last slide pretty much. So what's next? I've told you about these case studies. We are expanding them. And if anybody's interested in any of those things, please reach out to me. That's fine. Next slide, please. And what's my closing message? So I repeat, we do not scale technology, we scale trust and thoughtful care, which in other words is transformation. Sometimes a checklist can be much more powerful than just an algorithm. And what are algorithms? Really, the algorithms, the audit tools that I've told you about, they are just checklists that have been kind of been finessed or refined in a way so that we are utilizing more emerging technology in those checklists. So if you haven't read the book by Atul Gawande, which is the Checklist Manifesto, that's a great book, and that came out much before AI, by the way, right? And AI must follow empathy, not the other way around. Empathy, equity, evidence is really our answer to this webinar's call. Thank you very much. Yeah, you can find me on social media and the book MedJack, which I worked on while I was at the Arkan University. A lot of the principles of innovation we did publish in the book MedJack. So if anybody's interested, you can look for it or get in touch with me. Thank you so much.
Thank you so very much, Prof. Really very, very practical and amazing examples you gave it to us. I think, like Vivek, democratization and institutionalization, I'm going to remember, and what resonates with me in your presentation is co-creation before computation. So thank you for that. Asad, we have a few questions, and keeping in mind the time, you did talk about in your governance discussion that we have to be looking at AI in more humanistic way. One of the questions came: do you see any AI, especially autonomous AI, in the near future that will work independently?
Yeah, that's a great question. I'm sure. Okay, so even when I think about, I talk about that we're kind of like, monitoring the AI. Not everything can be monitored, and I do feel at times that even when I go back to, for example, if I've created something like a checklist and I've utilized AI or Gen AI, GPT-4 not to kind of help me refine the thought process, I put it aside, I come back to it, and it's almost as if it's kind of like autonomously been working in the background or the backdrop, and it just gives me better kind of thoughts or ideas when I go back to something. So maybe it's already working. So I don't think it just kind of goes to sleep or it just goes away. I think these things are happening autonomously, and I just hope that we don't get completely kind of like sidetracked. But very, very much like what Vivek was saying, right? So democratization of innovation or
Yes.
democratization of AI. I would want to add that AI literacy is really important. So whenever we work with a healthcare workforce, doctors, nurses, even non-clinical people in our hospital settings, techies, standard emergence, engineers and business people, but they're working in the healthcare space. We have a lot to learn from them as well. And so we can democratize this process through building AI literacy as well. I don't know if I answered your question, but I want to get that thought out.
Absolutely. Absolutely. So the question which came, and that's a clarification, which absolutely has gone way over my head. I'm not sure if Shiraz, who has put this question, heard you properly. Kindly clarify if you mentioned using ChatGPT 4 or not for text summarization. And he's asking because he's thinking this ChatGPT is not medical grade LLM. Any
Right, right.
clarification, please?
Yeah. So that's a great question. So I'm not utilizing ChatGPT or GPT-4 not specifically as a medical grade LLM. What I'm utilizing it for is uh, curating my references as well. So for example, when I generate
Gotcha.
checklist. So I think this is a very important question. So I don't want people to walk away from this and think that I'm just utilizing, GPT and whatever medical, quote unquote, medical information it's giving, I'm putting it, incorporating it into the frameworks that we are running across the board in the hospital. So that's not what's happening. I use it to kind of pull up references, and then I utilize, or if I have PDFs or papers or something, for example, if I have other checklists or publications, WHO checklist. So I can run it through GPT-4 not, and I can then compare documents. It becomes really easy for me to kind of look at a lot of different documents and compare them using something like GPT-4 not that can do this a lot more efficiently versus myself running through each and everything, doing all of this yourself.
Gotcha.
Then I
Gotcha.
go through a lot of this back and forth. Yes.
Very good. Thank you. Thank you for the clarification. Even I understood this. So thank you for that. Asad, we have some questions, but we will move forward with the presentations, and when if time permits, or later at the end of the presentations, I might to you. So thank you once again for a wonderful presentation. So coming to our next presenter, we have Mr. Shaukat Ali Khan, who is also going to be talking to us about his experience on digital strategy and training transformation through AI in an academic and in a broader public health sector. So over to you, Shaukat.
Thank you very much, Zenat, and good afternoon, everyone. It's such a pleasure to be here, and very nice to see you all. I will run a short presentation to give you a context of who we are at Al Khan University, and then what we do within the information communication and department, where we put the foundation of for of course all this amazing work on AI based on what we my colleagues. I think we are doing a couple of those things as well, and then some more. So I will try to at least give you some visibility within 10 minutes about what we are doing in this world. Next slide, please. So Al Khan University is operating in 6 countries. We are part of the Al Khan Development Network. Al Khan University has 18,000 users, but Al Khan University ICT supports around 32,000 users. In addition to the Al Khan University, we also support all our alumni and then a couple of Acadian agencies for their back-end services and then front-end services as well. So we are, Al Khan University operates in 6 countries with around 400 locations. With 7 hospitals and around 350 healthcare centers and phlebotomy centers. And within the ICT part, we are around 310, supporting all our hospital and university operations in these countries. And this also includes our 5 campuses where we offer multiple degree programs. Next slide, please. Yeah, this short video will give you a sense of our platforms and also the foundation on with regards to technology. Right, please.
In the heart of excellence, where the spirit of learning, innovation, and impact converge, lies Al Khan University, a beacon of knowledge, health, and technology. At AKU, our philosophy, IQRA, impact, quality, relevance, access, are the pillars that form the foundation of the Information Communications Technology Division. AKU's ICT division is on a mission to ensure access to quality digital resources and technologies for all. AKU is already recognized as a leader in health and education, underpinned by its cutting-edge technology and highly empowered ICT division. ICT's strength lies in its diversity, which provides a conducive environment for women and individuals of all backgrounds to come together as teams, working across AKU campuses in East Africa, the UK, Afghanistan, and Pakistan. For example, AKU has pioneered the implementation of the first international standard electronic health record system at a hospital in Nairobi, Kenya. With plans to implement it now in Pakistan, the EHR system called AKU One Health is the university's largest non-physical infrastructure investment to date. Additionally, the development of award-winning in-house applications and the implementation of leading enterprise resource platforms, ERP, across AKU globally paves the way for AKU's technological leadership in all the countries where it operates.
We are already actively responding to today's challenges, from climate change, poverty elimination, nutrition, maternal and child health, to the radical impact of artificial intelligence on the ways we learn, work, and interact with each other.
AKU's tech leadership is further showcased through the conferences it hosts in different regions where it operates, focusing on the power of digital transformation in healthcare, education, and beyond. At Al Khan University, we don't just adapt to change, we drive it. We are not just shaping the future of health and education, but leading the way forward through technology. Join us in our journey towards a smarter, healthier, and more connected world. Aga Khan University, where innovation meets impact.
And so it is that we come together today, both as grateful inheritors, looking back on an accomplished past, and as eager explorers, looking ahead to an exciting future.
Thank you. Next slide, please. So I think this is just to give you an overview of the commitment we have from our chancellor and pro-chancellor, and also the board of trustees and our president, all the way to all the staff, because this is a complete journey which includes all segments of the community within the Aga Khan University. So this is overall the digital transformation, but because the topic is artificial intelligence, so I would like to just give a couple of examples of what we are doing. Next slide, please. So we started AI, our task force, a couple of years ago, and then we started working on almost more than 40 operational AI prototypes and use cases, and these are some of those ones. In addition, of course, we are, as you heard, that we have a electronic health record system which has a built-in AI functionality. We have implemented a radiology information system, PACS, which has a built-in AI, and I'm really happy to also share that in just last week we signed an NDA with PACS, which enables us now at Aga Khan University, where certain diseases we can get results from the radiology images within 15 seconds, and those would be of course sent to the radiologist, and then after verification, then those will go out. So we are doing what is available according to the best practices and according to the needs of our institution. And these are some of those operational AI use cases where our teams have worked on prototypes. Actually, some of them we have prepared the entire use cases, and we have put a lot of consideration with regards to ethical part of it, because that was one of the biggest ask from our board about all these AI implementations, how we are doing with regards to responsible AI part. And next slide, please. And these are other concept papers. As I mentioned, we have over 40 different type of, with regards to our operational part, with regards to our clinical management, health management, and I will just take one or two examples, a bit more details. Next slide, please. For example, we heard from other distinguished panelists about different use cases, scheduling clinical appointments, because as we heard from Vivek, that the biggest thing we see is a waiting time. So how we can streamline outpatient appointment booking with a user-friendly chat model for scheduling, and that's where we use the AI model to speed up and then give the visibility to our patient part. And next slide, please. And then what this does is that we used a GPT for Turbo, and then we put an API with AKU part, so it's an AKU GPT. And then how we did the proof of concept is that we made a functional call to fetch live data from our dashboards and then respond patient queries until appointment is booked. So it's a live real-time visibility for integration with our dashboards, and then self-service from the patients, and the outcome is platform to book appointment without human intervention. And this is to optimize our internal process, but at the same time reduce those waiting times in our appointments in all the areas. And with every use case, you can see that we have put a compliance part, because this is very, very important for us, because we are dealing with patients and patient data. Next slide, please. And then this is another example, auto generation of clinical notes. Next slide, please. Yeah, we record the speech using microphones, because I can give you an example of Pakistan. We have over 40 different languages people speak when they come to the hospital. These are English, Urdu, Pashto, Punjabi, different type of. So our models are picking all the different type of languages, and then at the end it converts that into an English text, which is then verified by the doctor, but also the patient before it goes to the electronic record. And here as well, you can see the compliance part. So there are a lot of different examples, but due to the limitation in the time, so I will just bypass a lot of slides. So if you can just go to the second last slide, because I wanted to give an example with regards to the education part as well. Yeah, these are yeah, can you go to the, yes. So you can see what we have implemented so far. We have implemented we have a AI in higher education policy, which has been implemented as it is available on our website. So if you can, and then we are on a daily basis, we are not only implementing policies, but also embedding those policies into our educational system. For example, one of our institution is an Institute of Educational Development, where we tailored all this AI knowledge into the coursework from all the years, actually, so that when our teachers will go out from our institution, they are enabled and capable to teach the AI part within our medical science and all the medical science courses. We have actually included the AI education in every year's part, so that when our doctors, nurses, and other graduates can graduate from our universities and our institutions, then they are already they have enough knowledge on utilizing and leveraging AI together with their professional knowledge. Next slide, please. And no, previous one. Yes, so you can download by scanning these different policies which are already available, and then you can see how you are doing. So I think just to conclude, what we are doing is that from Al Khan University, we are partnering and collaborating with a lot of academic institutions, the industry, technology companies from all over the world, learning from them, working with all of them, and then bringing all those best practices to the countries where we are serving, and these type of platforms where we are collaborating, we are engaging in dialogue, and then based on those we are identifying use cases and then implementing those on a rapid speed. And we have an amazing support from our board, from our management in dealing with this, because they recognize that this is the future if we really wanted to support better the communities where we are living. So I will stop here, and then you're very welcome to ask any question.
Thank you so very much, Shaukat. Wow, that was quite a exciting list of AI tools in your institution you have implemented. Before I get into the questions section of that, I want to know about that recording AI. How do you maintain the quality part of it? How do you evaluate that? What is the process of ensuring that various different languages are being interpreted? How do you do the quality assurance of that AI into real world?
Yeah, so what we do is that when we of course we are using different tools to collect that the recording of that one, and then we analyze together with our clinical colleagues even before we start implementing, right? Our models are trained on these type of things, and there we also train our models on diverse group of people, because we have patients coming from all the country, actually, from different backgrounds, to train the LLMs based on all those deviations and diversity. It took some time, and then this is an ongoing journey and ongoing progress of actually getting more and more accuracy into this. But before implementing any of this, we have a robust system of getting these through with our clinical colleagues. who are evaluating these, that the quality is acceptable. And then and as I mentioned, that what is very important for us is a compliance part. At the end of the day, whatever record comes up, it's very important for us to that the concerned consultant can verify, but at the same time, the consent is given by the patient. And as I mentioned, with regards to the radiology, where we've just started that amazing part. In 15 seconds, the results can be there, but still it goes to the radiologist first. The radiologist needs to verify that this is the right thing before it goes to the patient.
Very good. Thank you. So you really reiterated co-creation before computation. So we are seeing all these cross-cutting themes amongst our speakers when it comes to developing AI. Shaukat, talk to us about how do you do upskilling, skilling, and reskilling? Because a lot of AIs in your hospitals or in your university are student facing, clinician facing, physician facing. So how do you implement it and prepared your teams to adopt these AI?
Yeah, I think this is a very interesting question, and that's the biggest challenge, because you can see that there are so many AI companies. They can come every day and then they can connect. But I think, are we prepared to use these AI tools? So what we do is that we offer, of course, we bring distinguished distinguished speakers to come and talk about it. But at the same time, on a university level, we do a e-learning part, a learning part on each departmental area about what are the bases of AI. As I mentioned, this AI use in higher education, we published this around 2 years ago on our website, and then communicated across the board that these are some of the parameters of what we need to be mindful when we are using AI within the context. So it's a continuous learning, and then we have a internal committees who are responsible to oversight all these developments, and this is such a rapid change in our world that we need to keep up the work and then learn new phenomena, as I mentioned, from partners and from collaborations.
Great. Thank you so very much, Shaukat. And we will be coming back to you, getting back to the speakers at the end, if time permits. Last, very exciting presentation by Scott Mahoney. He's going to talk to us about AI's ethical use. Very, very important aspect for us to keep in our minds in the PHCs and communities. Scott, over to you.
Thank you so much, Seenat, and hoping that you can hear me clearly. I will be focusing on some of the ethical use within the primary healthcare setting within low resource and LMICs, but also really hoping, kind of as the last speaker on the panel, to synthesize some of the learnings that we've had from the colleagues as we move through it. It is sometimes the trick of being towards the end of the panel is, often people steal your talking points. But I'm really hoping that the talking points that are shared amongst the group are ones which are high impact and really important for people to understand. So we can go on to our first slide, please. Just after this one. Great, thank you so much. So this 11 million kind of healthcare worker shortage, we've heard it from Zenit, we've heard it from Assad as well, that we're expecting an 11 million healthcare worker shortage by 2030. That's 5 years from now. It's not far. To think back to the horrible days of COVID, that was 5 years ago, and it just feels like yesterday. To also put this into perspective, Assad mentioned that a lot of these will be in low and middle income countries. 86% of them, in fact, will be in low and middle income countries. And this is hugely problematic. To add to that kind of perspective, if every higher education training institution on the African continent were to run at full tilt for the next 5 years, there's no way that we'd even get close to producing those 11 million healthcare workers. And so we have no choice but to expand where we might consider improving the resources and ability of healthcare workers to manage the ever increasing burden of patients that we see through various levels of care. I wanted to drive home a few other additional information beyond just the 11 million healthcare worker shortage. But if we look at the 1.55 average healthcare workers per 1,000 population in Africa from the Africa Regional Report from the WHO, bearing in mind that this includes doctors, nurses, and midwives, it's far below what the universal healthcare targets are. So this really is an important point around the ability to provide care to the quantity of patients that come through healthcare settings in low middle income countries. Added to that, we have an additional complexity where in the AI space over the last year or two, we've seen rapid advancements in the performance of large language models and, of course, now large medical language models and large multimodal medical language models. We've seen great progress in these frontier models and their ability on various benchmarks and real-world settings to be able to navigate the complexities of medical information digestion, synthesis, and outputting diagnostic and treatment plans. There's often a criticism, though, what if it gets it wrong? Who is accountable? And it's one of the key ethical questions. I often challenge this with the thought of if we look at the data from World Bank and we sit realistically at a higher end of the threshold, the percent of correct diagnoses in a country like Tanzania is 69.2%. The lower end of the spectrum, unfortunately, is Niger at 39.9%. And these are correct diagnoses in these low resource LMIC settings. So we have to then ask when AI may only perform at 80 or 90% accuracy, compared to what? Compared to the existing state of care. And so is there an opportunity here for us to try and augment our healthcare workers with clinical decision support processes, with workflow efficiency optimization, and really try and answer the question of not just how do we deal with the quantity of patients, but how do we improve the quality of the care that we provide to those patients as well? To double down on this point, obviously, many of the people in the audience will be very aware of the Lancet's Global Health 2050 report, which kind of detailed out halving premature deaths by the middle of the century. And there are some sort of 15 key conditions across both infectious disease and non-communicable diseases and recommendations attached to those. I would challenge those in the audience and certainly on the panel to really think where those kind of improvements and priority areas are, is to think about where we could augment these with AI as well. And I think we would start to unlock some unique opportunities and start to hit really realistic targets in improving premature deaths and diagnostic performance and treatment performance across both quantity and quality of care. The last point that I wanted to highlight around, and I promise I am timing myself to keep us on track here, Zenith. The one thing that I wanted to just touch on before we move on to the next slide is something which is very overlooked in our settings is the cost of healthcare is not just a cost that a state or a public health system or a private insurer pays for, but also the cost that the patient pays for. And one of the largest cost drivers in healthcare exposure for people utilizing public health systems is transportation costs. 1 in 6 people in sub-Saharan Africa live more than 2 hours from a public hospital, and 1 in 8 are more than 1 hour away from the nearest public health center, whether it's a primary healthcare center. So I really want to challenge, how do we start thinking about improving reach extenders, whether this is through virtual care. And as we see from GSMA reports that connectivity is increasing steadily across the continent and certainly in sub-Saharan and South Asia, there are opportunities for us to start to improve the reach and provision of care for people even in their own homes. So we can move on to the next slide, where I wanted to just run through some potential opportunities, and credit to folks on the team, on our primary healthcare team, Melissa Miles, who is doing incredible work in primary healthcare and AI opportunities. Where do we see potential opportunity to improve expertise at each touch point or entry into the health system? Now, we've heard from colleagues on the sort of panel, and Vivek made very clear that patients often spend most of their time waiting in facilities. I would even go so far as to say that they're encouraged to hurry up and wait at these facilities. And that's really sad, in that there's an opportunity in that cost time to them where they may be taking a day off work, paying for their transport, which is often unaffordable. And so how can we optimize their process through a clinic where, say, in a primary healthcare setting and most low resource settings, a patient is spending a full day in a clinic just for a chronic disease follow-up? That means that most of their time in that clinic, less than 10% is value add in a clinical context. So where are the opportunities here? Let's first look at some of our largest gains or benefits where we hypothesize seeing improved opportunity to improve their care offering. So firstly, if we look at the bottom of the pyramid where we see AI and self-care as an opportunity, colleagues were, mentioning some of their health apps. I think it was Family Hifazat, if I'm not mistaken, from the Aga Khan team, where people are able to access their own health records, they're able to understand and democratize their information, they're able to have portability of their record, which is often a barrier in low resource settings where longitudinal record portability is very poor. It's kept at specific facilities instead of patients ethically having autonomy of their records and their ability to maintain their care, which is a direct contributor to improving their quality of care. We also see an opportunity to augment health workers. Knowledge assistance, as a lot of EMR systems are moving towards around clinical decision support tools. One of the biggest challenges we see with large language models is that they are abstractive by nature. And so trying to work strongly in a field that drives them towards deterministic decision-making tools goes very far in strengthening their reliability, safety, and acceptability in these settings, especially embedded into EHR settings. I think we also see an opportunity to reduce costs per interaction for patients when they are seen. We're hoping, that routine processes, and we've seen this with some of our grantees, especially in Pakistan, actually at Shalimar Hospital, Awaz Sahat is doing some incredible work in a voice-enabled EMR system in the obstetrics unit, where clinicians often have less than 2 minutes to see the patient because of the burden of disease and burden of patients. They're able to record consultations in Urdu that are then automatically transcribed and captured into a longitudinal EMR antenatal record. And it then goes one step further where it's able to flag really high risk pregnancies. And the potential for that to reduce maternal morbidity and mortality is immense. The other area that we just pivoting around the whole ambient scribe space is the reduction in the admin burden. I was at a primary healthcare clinic down the road in Cape Town where I'm based, and the nurses in their HIV and TB unit reported that they spend up to 3 hours a day just writing clinical notes. If we're able to effectively utilize ambient scribes that pick up on nuances, who are able to deal with ambient noise within busy clinical settings, we might have a very, very pivotal change in how health systems function and improve the ability for a clinician or healthcare worker at large to be able to improve their therapeutic relationship with the patient by being able to focus on the patient in front of them rather than how they record their content. Another kind of key area just to touch on very briefly is how we enable systems visibility. We often talk about all of these tools because of their ability to process patient data at the clinical interface. One of the massive spin-offs of this is the ability to actually leapfrog healthcare systems where there isn't as good a digital maturity, especially in sub-Saharan African settings. And we are able to consider leapfrogging forward, utilizing AI to build out robust digital records for these patients. And the beauty of that is from that granular level, it funnels into fantastic data systems that improve surveillance, hotspot identification, especially around infectious diseases or issues around quality of care focused on maternal health outcomes, under 5 mortality. And so this is really important for policy and decision making. So really what we're trying to see is at each of these levels, where are the opportunities to deploy tools that would be able to function in this space? I wanted to pick up on Vivek's note around kind of a 2 to 2.5 times multiplier in managing patients within the same infrastructure. And I would go so far as to say where in low resource settings where most of the care is delivered at primary healthcare or community orientated primary care settings, I would see and challenge us to say, can we see a 10 to 15 times improvement in the ability to manage patients, especially unlocking the self-care piece, which improves patient autonomy from an ethical point of view. I'm going to shoot to the last slide in the interest of time, because I do know that we want to keep some time for discussion. And I've just put together some very broad points. And just by the way, this is GPT's new kind of image generation model. And it was astounding to see how fantastically it pulled together what a future state might look like. But to touch on some of the points, Asad mentioned co-creation before computation, and I think a few speakers have picked up on this. What we've seen in places like Rwanda, where they've really advanced their digital maturity with their Ibuzima EHR system, is they focused on co-creation before and during computation. And so they deployed their software developers and engineers into primary healthcare settings to work with the health workers and say, does this iteration look like something that you'd be able to utilize on your daily basis? And that is an absolute sweet spot for community-led co-creation across the board. It also helps with the engagement with systems change. There's more representation, and we also see improvements in the AI literacy of those staff as well. Shakat also built on the pre-service training AI exposure in medicine, and thus feeds into the ability for human resources for health AI strengthening, is making sure graduates are coming out of university ready for this brave new world where AI augments and potentially and hopefully improves their health services delivery. I just want to touch on a last few points on these building blocks, which are very broad strokes and meant to be kind of conversation starters, is that we also need to think carefully around where we're integrating frontier models, that we are very clearly being able to make sure that they are contextually relevant within our settings, which have different needs, making sure that their biases and gender normative standards are being addressed and assessed very clearly. I think gender is something which is very overlooked in this space, especially considering that the bulk of healthcare workers in sub-Saharan Africa are female. Then, in addition to that, is a key driver on interoperability when it comes to data. How are we making sure we're setting up AI tools that are not shiny standalone systems, but rather interoperate? Because patients don't remain with a single service, they don't remain with a single app. They utilize various channels of communication, they utilize various health systems, and we need to make sure ultimate portability and integration and interoperability across that space. The last key point that I really want to hone in on is very rigorous monitoring and evaluation processes. That is the only way that we can make informed decisions on the performance of these tools. And a lot of speakers have mentioned this. It also allows us to make rapid and clear evidence-based decisions around how we pivot or adopt different models, language models into our tools moving forward. I've gone 4 minutes over. I've timed myself, Zinat. It was 14 minutes, 24 seconds, and I'm going to pause there.
Oh, thank you, Scott. Very, very exciting presentation. Scott, I want to take your question from your last slide, and that's about governance. When public health, when we talk of public health, we are talking of huge scale going into the communities. How do you see a governance model which could be put in place in AI to reduce the biases and protect the vulnerable populations? What are your thoughts on that?
Zina, it's a fantastic question, and one that I think many people in this room and on this webinar and, quite frankly, on LinkedIn are all very, aware of. Governance at its core needs to start with consultation processes. Now, the difficulty with any governance procedure is that the time that it takes to develop out a very robust governance procedure that has heavy consultation, the time is very long. And ultimately, what we see in the same process with kind of HREC or ethics board approvals for a lot of work, especially around AI, is significant delay. And we have this ever widening, what I call a pacing problem between where we are now, where the technology is, and where the kind of governance processes are. And that gap is actually widening as we go because the technology is moving so fast. So really, I think the first is, as we're talking about health systems reform or health systems kind of wheelhouse changes with AI enablement, we also need to talk about the data governance that underpins that. Who are the key stakeholders that need to be brought along for the journey? Who are the people that we need to consult in communities as well, where these tools may affect them? And how do we bring them to a table that iterates as much as people do in software development life cycles. How do we iterate over that data governance in a very rapid data governance cycle as well? And I think being able to facilitate that would be a key to unlocking the regulatory processes that these AI tools one day will need to go through. It will be the key to unlocking research methodologies and kind of novel evaluation approaches that need to go through ethics approval processes, and making sure that data governance at its core is representative and fair. And we're not talking just about politicians or policymakers, but also deeply about gender representation and around this right stakeholders, including academia.
Absolutely, absolutely. Well, thank you so very much, Scott, for a detailed answer. And I agree. Perhaps an AI on governance would work as well. Who knows? Coming to, we have 4 to 5 more minutes. I have a question which I would like to put it on the table from one of our participants. Do we inform our patients about use of AI in their care? Dr. Asad, as a clinician, and Shaukat, you talked about quite a few of them. If you can briefly tell us about it, and then Vivek, I will come to you for another question. Your thoughts, gentlemen?
Yeah, so very quickly, I mean, because AI utilization in the clinical workspace is relatively new for me as well, and all of this year I haven't done any clinical work. So, but while I was in the emergency department, because I'm a pediatric emergency doc, um, I did work with students at the Arkan University. So, if they were like students rotating or nursing students or medical students, I would always actually tell them to kind of look it up on GPT. This is a really interesting case, and they're unable to come up with a diagnosis, and this kid comes in the emergency for something, and we thinking about, okay, what could be the diagnosis. So I would always encourage them to look it up and say, okay, let's just kind of think about what's the ethics of you utilizing something like this, and so on and so forth. So it always end up being a very good discussion point. But in actual practice, I haven't.
Okay.
So yeah, that's what but it's just I have used it if some family member, somebody has shared something like, like a skin rash, for example. So I'm guilty of that. I have run it through GPT. So, okay, what could potentially be the cause for the skin rash? So I've done that.
Gotcha. Shaukat, have you instituted any formal
Yeah.
sent forms to utilize these variety of AI modules in your academic institution?
Yeah. So a couple of things, as I mentioned, with regards to the higher education, AI use in higher education, we have a policy, and then everyone has to comply with that policy. With regards to all the clinical part, as I mentioned, that one of the most important thing which is great at the moment, we are on an early stage concept which we are doing, and the one of the requirement for production is that first thing is that inform the patient that we are using this. For example, we are recording their discussion with the consultant, then the patient needs to agree that he or she are fine. And at the end of the day, once their session is complete, then again the consent is important, that they are happy with what has been recorded. So I think that has been part of our entire process. So when we are going to put this in the production, you will see this as a process.
Great, thank you. And I think it goes back to governance. It goes back to protecting our vulnerable population and patients and the communities. So thank you. Vivek, a question to you. We all are from the countries where, or we work, or we are looking at the countries where human resources is galore, and we have people unemployed. And with this AI coming, do you get this message from your staff that their jobs is going to be compromised, or their jobs will go away because AI is going to come? Do we hear that from our staff in your organization? And if you do, how do you counter that?
Definitely, there is a fear that AI will replace a lot of jobs. But specifically from a healthcare perspective, is the entire population actually covered for healthcare? Does everyone have access to healthcare? No. Which means the staff that we have is not enough. That is the underlying point. So how can we multiply the power of the existing staff is what we are looking at. What will happen is instead of treating 10 patients, they will start treating 20, 30, 40 patients powered by AI. AI is like additional staff that they get. And as I was saying, very soon we should hit 100% of the population having access to good quality healthcare. That is what we see happening. And people have always moved on to role elevations.
Mhm.
Of course, no other AI revolution has been like the one that we are seeing over the last 1, 2 years. Everything else was specific AI to solve one specific problem, maybe one chest X-ray interpretation or one lab test interpretation. What we have now is broad-based AI, which is a single system that can do multiple things. As the earlier speakers were saying, now documentation is automated in our hospital, which is saving a lot of time. So a lot of things that earlier human intellect could do, AI is now able to do on its own very well because it is now broad-based AI. That is presenting a threat. Uh, and it will be interesting to see what happens in the coming years and how the roles elevate. But I think the quality of care and the nature of care will itself fundamentally change from the way we are delivering care today.
Well said.
And
Well said.
people
Thank you so
powered by
much.
AI will be able to do much more than what they are doing today.
Can
Very
I
good.
add
Thank you,
one
Vivek. Well
comment?
said. Yeah, Shaukat, very short comment because we are about to close.
So I think this is very very interesting question, and just to refer back to the World Economic Report, they are saying that 44% of workers' skills will be disrupted by 2027 because of AI, right? And there are many other reports which are saying, and as Vivek mentioned, remember that still 2.9 billion people, they don't have access to internet as of now. So the opportunity is so big that whatever we can do to leverage to enable this access. Thank you.
Sure. Thank you. Thank you so very much. I am so grateful to all the speakers for a wonderful, for all your presentations and the interaction. We are taking some very important messages back home to our own institutions related to how do we do ethical AI, how do we ensure democratization, co-creation before computation, people come first, training, retraining, reskilling, and so forth. So thank you all for your time and sharing your experience. With that, may I please pass the mic to Aditi?
Thank you so much, Zinat, and thank you so much to the speakers as well. Let me go ahead and invite Pierre Kempf from the French Development Agency to provide closing remarks.
Okay, good morning, good afternoon, everybody. I am very pleased to be part of this discussion and this webinar this afternoon. Frankly, the most important thing was what we heard from our great speakers, and I have I mean, I have no position to say and to provide any additional things. But we saw that the health system is facing multiple constraints and that are in constraintly affect the accessibility, the continuity of the quality of the care. In this context, we saw a couple of examples using artificial intelligence that may help to provide promising solution regarding those constraints. Sorry. So we are, as AFD, very proud to be part of these reflections on this transformation of the health systems. As we see the example in Nigeria, Kenya, Rwanda confirms in a very concrete way the opportunity of using IA in the health system and in the transformation of the health system. we understood that the important is co-creation before and during computation. It would be the keywords of this webinar this afternoon. But beside that, I have to say that we should have tried to use EEI to summarize this webinar in order to test those solutions on our discussion. The second remarks, I would say that probably IA or EI, it depends on the language, might be an activity for women too, because we had four men presenting, so probably there are some women working on those subjects, and maybe aside of thanking very much our colleague from IHF and Zinat to have very dynamically animate this webinar. Maybe I can give you the floor for one or two information. Maybe to remind that in September we'll have a webinar on quality of care. Maybe you already know the date, so you can say, and also to remind you the Congress, the International Congress of Hospital, and especially the side event that we are organizing on the 13th of November. But I let you, one of you, maybe give and provide our audience some details about those events. Thank you very much for the presenters. Thank you once again very much for the organizer and Zinat, and thank you very much for all of you to have attended this webinar this morning or this afternoon, depends on where you are in the world. Thank you very much.
Thank you very much, Pierre. Just to be able to let the audience know, I know we're a couple of minutes over, but with regards to what he was mentioning, we will have a side event for the future of hospitals and health systems in November, right alongside with the World Hospital Congress that's taking place in Geneva. This will be on November 13th. So please keep an eye out for further details. And in addition to that, we also have 2 more webinars coming up in September. So that'll wrap up our summer webinar series. And thank you all once again for your time, for your attention, and for being here and being present. So much appreciated, and have a good rest of the day.